And at Nicholas Children's, we do have a spine team. This says part one. Here I am here. Here's John Ashkar, who's in the other room, and it's our nursing staff. And we'd really approach the patient in a really as a team sport, honestly. And it's part one because our fearless chief is not in this picture, and I couldn't figure out whether it was because he was in clinic or whether he's just a ladies' man, because he did take a picture with them, and that's Dr. Shufflebarger, who's not with us, but that's the rest of our team. And as an overview, during this I want to do a review on the historic perspectives, also a lit review on what we know, also the effects on the heart and lungs, and AIS as a cause of back pain, and some thoughts on psychosocial assessment and appearance, and then really what does it all mean. So as we look at historic perspective, and we look at the earlier studies that were done that looked at the natural history of non-operative treatment, the reports were pretty grim. The prognosis was grim. There was a lot of thought that there was an inability to maintain employment, inability to get married, the development of heart failure after lung failure, and then debilitating back pain. In some of the earlier studies, 1968, this is a group out of Sweden, they looked at 130 patients who were untreated scoliosis patients with 38-year follow-up. And the results showed that 30% reported disability due to the deformity, and 100% increase in mortality compared to the normal population. And the caveat to that, however, and we'll see that actually as a thread throughout, is that 45% of these patients had idiopathic scoliosis. And as we know, the idiopathic scoliosis in the adolescents is very different than some of the other types of scoliosis that we do treat. So we have to be very careful when we look at the literature to be able to decipher who was actually in these studies. Some more of the earlier studies. This is another one by Nielsen in '68, and it showed that in 113 patients with idiopathic scoliosis at 50-year follow-up, 90% had back pain, 30% the patients were receiving disability benefits, and the mortality was twice the rate of the general population. But when we look again closer at the data here, the caveat would be there was no differentiation between early onset scoliosis and adolescent idiopathic scoliosis. And again, those are very different pathologies, and the early data didn't really decipher the two. So a common limitation of these earlier studies was that the population was heterogeneous. So they had congenital scoliosis, neuromuscular scoliosis, early onset, all mixed together. And so the data is what we consider dirty in that regard. And there were, since there's several differences, a lot of these landmark papers, it's hard to extrapolate what that means for the AIS patient. So the Iowa studies have been sort of a landmark group of studies in this field. And it's a group of studies that look at the natural history of AIS particularly. It was done in a single institution in Iowa on one group of patients over 50 years. Some of the possible limitations with these studies, however, is that there was a very limited population with limited social, economic, and cultural diversity in that sample. And a lot of that affects some of the patient reported assessment tools that we use when we look at the long-term outcomes of these conditions. So in the study, it was first described, the population was first described by Ponseti and Freeman in 1950. And they described 394 patients in a short-term study that was about 2 to 5 year follow-up. And then the subsequent studies used that same population. However, as happens in long-term studies, there was several patients that were lost to follow-up, and several patients had to be excluded because it turns out they didn't have adolescent idiopathic scoliosis to begin with. And then other patients, the data set wasn't complete. So as we look at the bigger studies in this series, the 30-year follow-up study included 195 patients, the 40-year, 161, and the most recent 50-year data was done on 117 patients. Now, that may sound like a lot, but when you start looking at the different types of adolescent idiopathic scoliosis, whether it's thoracic or lumbar, and you start looking at the ages, the groups become very small. And what that means is that we have to understand the natural history on a very small group of patients. So just keep that in mind as we look at some of the studies. So what did we learn from some of these Iowa studies? First is that curve patterns behave differently. So when we look at a thoracic curve, what we found was they tend to be the most vulnerable to progression. Weinstein, who's actually at this meeting speaking just down the hall, in 81 published some data, and it showed that curves 50 to 80 degrees at skeletal maturity increased an average of 11.3 degrees over a 10-year interval. He again in 83 published another paper saying that curves 50 to 75 degrees demonstrated the most progression. However, that was only based on 11 patients in that study group again. When we look at thoracolumbar curves, Weinstein looked at a 40-year follow-up and curves over 30 degrees. There were 8 patients in that group, and the mean magnitude of the curve was 56 degrees. And he found that there was an average of 20 degrees of progression over that time period, which is about a half a degree per year. Another study looking at 34-year follow-up on the same group of thoracolumbar curves showed that at 40 degrees there was sort of a threshold where those patients with curves larger than 40 degrees progressed 19 degrees over that same time period, and those with a curve less than 40 degrees only progressed 10 degrees. Now, when we talk about lumbar curves, the 29-year data that Weinstein also looked at, he reviewed curves over 30 degrees. There were 17 patients, and the average progression over that 29-year period was about 16.5 degrees. So that's over a half a degree per year. And this was a similar study was done looking at 29-year follow-up, and it had similar results. So what about the heart and lungs? So many clinicians and researchers have theorized that severe scoliosis leads to cardiorespiratory failure. And some studies suggest that there are limitations in cardiopulmonary function when your curve gets to be over 60 degrees. There also has been sort of a relationship saying that the magnitude of the curve or how big the curve is inversely related to your pulmonary or your lung function on some specific tests that we can do. And then other studies use 100 degrees as this threshold where they say that you have significant decrease in lung volume, which leads to diminishing return, well, clinical implications basically at 100 degrees. But again, these reports, this research has limitations in and of themselves. And again, it goes back to this heterogeneous group of complex deformities. So again, when you include early onset scoliosis, which is very different than adolescent idiopathic scoliosis, it's very hard to figure out, well, does this actually pertain to an AIS patient? So in conclusion, insofar as the heart and lungs, the literature doesn't support the hypothesis that AIS leads to cardiopulmonary failure later in life. That's assuming there's no underlying condition, whether cardiac or pulmonary condition, that it would precipitate. AIS can cause a reduced exercise tolerance and pulmonary function on these specific tests we do, but we're not sure what that means or what the clinical consequence would be of those small differences. And this again is very patient specific. The next thing is, what about back pain? In general, AIS doesn't initially cause back pain. Adult scoliosis, on the other hand, or adults who present with scoliosis, they often present with disability and back pain. And when we look at what are the causes of adult scoliosis, one of the causes is possibly a late manifestation of untreated adolescent idiopathic scoliosis. But there are several other reasons why you could have adult scoliosis, so it's hard to pin AIS on the reason why you would have scoliosis as an adult. It could be from a limb length discrepancy, other deformities, osteoporosis, or just arthritis of the back. In 97, a paper was put out looking at a 22-year follow-up on 34 patients with thoracolumbar and lumbar curves. And what they found was that 65% of patients with scoliosis in this study reported back pain, and that was when you compared them to their age-matched counterparts that they were found to have 32% back pain. Weinstein, in his 50-year follow-up that was put out in 2003, said that on average, the patient with scoliosis does have a higher incidence of developing back pain. However, the duration and intensity was actually similar to their age-matched counterparts after 50 years. So, in conclusion, in regards to back pain, AIS doesn't initially cause back pain. There is a higher likelihood that they will develop it in adulthood, but it's hard to know exactly what the actual cause of that back pain is in adult, whether the adult scoliosis is caused directly from the AIS or any of those other factors that we talked about. When we look at psychosocial and appearance issues of patients with scoliosis, again, there's numerous studies that look at this, but there's no clear consensus. And as we go through historically, in 68, Nachemson again reported that many of his patients were receiving disability, and a large portion of them were unmarried. In 86, Ascani put out some research saying that he had real psychologic disturbances in 19% of his patients, 94% of which had curves over 40 degrees. So this kind of shook things up, but in 2003, again, this 50-year data shows that most of these patients are gainfully employed, 90% are married, less than 20% had any psychologic effects from the deformity at all, which kind of paints a more benign picture to the long-term, these long-term follow-up patients. So some common limitations again. This is a very subjective matrix. Depending on where these studies are done, what generation they're done in, the reports will be very different on how these patients are doing. And that means a lot when you look at the data and you try to figure out what that means for you as a patient or you as a family member. So in conclusion, it is extremely difficult to describe the long-term natural history of non-operative AIS. Perfect follow-up is really impossible for these types of studies. The study population is often biased, not intentionally, but because of where the study is done and who's doing it and how they perceive themselves and what they would accept aesthetically is very different. So patients' expectations will vary depending on where you are. And the subjective data is not always translational, so we have to understand that. But with that said, the prognosis of non-op AIS is not as grim as we once assumed, but it's not always benign either. Larger curves tend to progress even after skeletal maturity. The larger curves also affect cardiopulmonary function, but we're not sure where the threshold is and what's the clinical significance of that threshold. AIS is associated with late onset back pain, but untreated AIS patients lead enriching and enjoyable lives as well, so we have to understand that too. So what all this means to me is that we should treat AIS on an individual basis. It's really all about the patient. These guidelines and studies set a framework for our treatment, but by no means is this an algorithm of how a patient should be treated. Patients and families really should be empowered by knowledge, support, complete autonomy, cooperation with your surgeon, and realistic expectations. Thank you.